And now the next speaker is Amanda Ria, again from US, is a clinical manager. Hi, Amanda. How are you?
Good.
So, and she's going to talk about, again, a guide to goal-directed fluid therapy. Yes,
Thank you
please.
so much. Thank you so much for having me. I was a little bit paranoid about connection, so I did pre-record this talk that I'm going to share with you now. I kind of look at goal-directed therapy kind of like part of a book. Can you see my screen?
No, not yet.
All right. Let's try here. Oh, there we go. There it goes, I believe. Got it now?
Hello, everyone. My name
Yes.
is Amanda Ray, and I'm a nurse practitioner with the Division of Cardiac Surgery at University of Maryland, St. Joseph.
You lost again, Amanda.
Let's see here. Share, present, share screen.
So you probably press the stop button.
Okay.
They say that may be the reason.
All right, it should be getting ready to go here now.
Yes.
Hello, everyone. My name is Amanda Ray, and I'm a nurse practitioner with the Division of Cardiac Surgery at University of Maryland, St. Joseph Medical Center in the USA. I want to thank the organizers for inviting me to speak to you today, and we'll be talking about a guide to goal-directed therapy. These are my disclosures. First, I want to talk about the fundamental concept of goal-directed therapy, or GDT. And ideally, we want to match the patient's needs with treatment. We want to individualize the administration of fluids, vasopressors, and inotropes, but in a standardized way. What we hope
Can
to
you
achieve
press the hide button,
therapy
Amanda?
is assure that we have perfusion adequacy. We want to avoid utilization of patient's reserve and optimize their recovery and outcomes. Essentially, we would like to give the patient the right thing at the right time. GDT also allows us alternatives to the PA catheter. We're able to have less or non-invasive monitor availability, especially for lower risk patients. And these algorithms should be guided by stroke volume or stroke volume variation. One of the things you likely hope to achieve with a goal-directed therapy algorithm is a reduction in AKI. We know that cardiac surgery patients specifically have areas of mechanisms of insult that can attribute to AKI. And those are things like extracorpuscle circulation and perioperative drugs, low cardiac output syndrome, embolisms, and obviously bypass. Research for cardiac surgery patients has been building in recent years, although we still lack a large randomized control trial. Peer-reviewed literature, however, has showed reductions in length of stay for ICU, as well as total length of stay, morbidity, AKI, and infection. Also, the Enhanced Recovery Guidelines from the ERAS Cardiac Society, published in JAMA Surgery in 2019, listed goal-directed fluid therapy as a Class 1 Level B recommendation. So if we look at some of the literature, this meta-analysis that was done by Chung looked at over 11,000 patients and found a reduction in morbidity and mortality, specifically pneumonia, AKI, wound infection, and hospital length of stay. This randomized controlled trial had about 120 patients and showed a reduction in 30-day major complications, specifically infection, as well as low cardiac output syndrome, as well as ICU and hospital length of stay. Thompson looked at 260 patients and found a reduction in ICU and hospital length of stay, as well as AKI. Ganot found a shorter ICU length of stay, as well as vasopressor dosing. This study showed in ICU length of stay, it was about 100 patients. And lastly, this meta-analysis found a reduction in post-complication rate as well as hospital length of stay. So these studies help highlight the importance of goal-directed therapy, which includes reduction in AKI, shorter length of stays for the patient, reduction in infection and vent hours. The other thing that you're hoping to achieve is to maintain euvolemia as much as you possibly can and reduce the amount of hypervolemia that is unnecessary to a patient. This will reduce pleural effusions, pulmonary edema, AFib, as well as not having patients who are under-resuscitated and maybe with low blood pressure, low cardiac output syndrome, or orthostatic hypotension. We utilize a nurse-driven algorithm with 250 cc boluses at a time, and our personal algorithm that's listed here is driven by stroke volume. There is also a QR code, if you notice in the lower corner, that has about 10-ish published GDT algorithms that are guided by stroke volume variation. I think there's even one that's driven by CVP, so that hopefully it's something that you can utilize with whatever equipment that you may have at your facility. So let's talk about some implementation barriers that you may come across. Likely your staff may have a satisfaction with the status quo. They think things are going good as they are. They may feel a loss of autonomy or flexibility, especially if you're having a standardized algorithm when they previously chose more individually what happened with the patient. They would have an interruption in their current workflow, especially if you're talking about new equipment. They may have cognitive overload or temporary incompetence. And then you also have to prove to your C-suite the value of what you're doing. So let's talk about some potential solutions for these limitations or barriers. So you want to get preliminary data and audit that data, compare your results once you've implemented goal-directed therapy, and tie those to numbers to help prove to your C-suite for any equipment you may need. You want to get early and continuous stakeholder input. You want to give comprehensive education and discussion sessions. And when, like implementing anything, you want to reach everybody and every person so they understand and everyone's on the same page. You want to make your algorithm as user-friendly, pragmatic, and non-threatening as you can, and make sure no one is variating from that algorithm when you're trying to assess if it's successful or not. Just for an example, I thought I'd bring you a little bit of data from my facility when we were starting goal-directed therapy here. Our retrospective cohort was around 129 patients, and the GDT cohort was 222. We chose to use isolated patients with an EF of 45 or greater when we were initially testing the goal-directed therapy algorithm, just as a cost-cutting measure. We found a reduction in 4.7% of our post-op 2 AKI, a reduction in 2.1% of our post-op 7-day AKI, and a reduction in 2.6% of our average discharge AKI, and that is by KDIGO criteria. We also found a reduction in 7% of our atrial fib rates. Albumin was not on our algorithm, but seemed to be occasionally used, so we definitely found a reduction in our albumin usage. But we also found that we were giving about a liter more of fluid to our patients post-operatively, and we looked at IV fluids in a 48-hour range post-operatively. We didn't find much difference in our vasopressor hours. However, where we did find some significant changes were we had about a 10-hour reduction in our ICU length of stay. Our ICU readmission rate was reduced by about 1.3%. Our average post-op length of stay was interesting to me because the average for these patients is about 7.8 by STS, risk-adjusted metric, and we already are well below that average at 5.6, so we were still able to reduce it by about half a day. And the largest change we saw was reduction in hospital readmission. Before starting GDT, we had a 13.2% readmission rate, and we brought that down to 0.5. And when we had looked into that readmission rate before we started GDT, we found that most of our readmissions were related to some type of volume overload. Pleural effusions, could potentially be AFib, or pulmonary edema. So I want to thank everybody for listening to this presentation. And again, thank you to the organizers for the invitation. If anyone has any questions, feel free to email me. I'm happy to share order sets, algorithms, whatever I have. Thank you so much.
Thank you very much, Amanda. Any questions? No? Okay, so I want to ask, so in order to organize the goal-directed fluid therapy, so do we need really any monitorization techniques, or we can use any methodology without the help of the new technology, for example?
So I think ideally you have a device that can give you stroke volume or stroke volume variation. Rather that comes to be a continuous PA catheter or a minimally invasive device. There are even algorithms. You can start by using almost a poor man's algorithm, and there's algorithms. Some of the ones I listed in that QR code are driven by CVP. And cardiac index. So I think you can do it even if you have a PA catheter, but obviously, ideally, most of the data is between stroke volume or stroke volume variation.
Thank you. Okay, so thank you very much for your presentation. Bye-bye.
Thank you so much for having me.